Hello and welcome to Dento Tattva. This is our brand new section, DentoGraph. We take up random radiographs from our routine dentistry and try to understand the story behind it. For today's session, this is the radiograph that I have chosen. Now, few of the important observational points that you need to keep in mind. First, the tooth in question. Then will be the root end or the apex of the tooth. The adjacent teeth could also be taken into consideration if there is a large periapical pathology supporting bone, PDL, that is the periodontal ligament space, and the LD, that is lamina dura. So once we have observed all these things, we can draw conclusion. The present is of 1, 1, 1, 2, 1, 3, that is right maxillary, central incisor, lateral and canine. And the circle of the infection, the main periapical pathology, is actually the center is in relation to 1 to the periapical end. It is extending from the distal part of 1 1 to the mesial part of 1 3. So there is a high probability that if we do a pulp vitality test with a pulp tester, that 1 1 and 1 3 along with 1 2 could end up being non-vital. Now, carefully observing the X-ray, we need to first understand the lesion and final diagnosis related to the type of lesion, whether it is a periapical abscess, cyst or granuloma. But based on the size, since this is almost 1 centimeter in size, we could say that this appears to be a cyst rather than a simple abscess. But the confirmation will once be done when we have approached the lesion surgically and we give the sample, either if it is a fluid filled cyst, a fluid filled cavity, or the granulomatous tissue that is obtained once the cavity is opened. That sample could be given in a while to the oral pathology department and then they can make the confirmation for you. The first step to this is, once we are done with the radiograph, we first need to see the extent of the lesion, what all teeth have been involved. In this case, we can even see that there is loss of bone in the region. And because of loss of bone, there is a high probability that the patient might come to you with a mobile tooth, and in such extensive cases, there is a possibility that the tooth might be depressible in socket because of the loss of bone structure and possible presence of pus in a lot of cases, because there is resorption of the entire bony structure and there is pathology. There is non-vital pulpal tissue which possibly lead to bacterial ingress and growth. So there could be a presence of sinus tract, and if you do the sinus tracing, it could lead to the tooth in question. That is, in this case, if we would have done the sinus tracing with a 2% 25 number GP, possibly would have led to the root end in relation to 1 2. If it is diffused and the size of the lesion is small, then our initial diagnosis could be related to periapical abscess. If the lesion would have been smaller, we can even approach it non-surgically. So with this, I'll end today's session on DentoGraph. I hope this was helpful in some way. I'll meet you guys again with a new topic in the next lecture. Bye.